Okay, so in 2007, I started losing my voice. And with that, the better half of my partner was saying, go and see a doctor, go and see a doctor. Me being a male, I just kept on thinking, oh, it's only a bit of laryngitis. It'll get better, and basically it was getting worse and worse and worse. So with that, I had this surgery. So then I asked the doctors, and I said, well, how long was I in there for? And they said, well, you're in there for 18 hours. We had 16 people working on you. So I was there in hospital for 3 weeks, recovering, learning how to walk again, because it really did knock me around a bit. And so after that 3-week period, I got home, and then I started basically getting ready, seeing other doctors in a different hospital to get ready for radiation and chemotherapy. The oncologist at the hospital, they said, well, we're going to do the radiation, but we'll also give you chemo, and that's more of a backup to ensure that both work hand in hand. I purely breathe through the neck now, so the nose is just ornamental. It's only there for show. So if I want to do a nose job, I will. The changes that are post-surgery are permanent. They're not reversible, as in if someone has a tracheostomy. These are basically what you see is what you get. With this video that you're watching, this will hopefully assist the professional staff in identifying and helping laryngectomies whilst they're in hospital care and also perhaps in emergency.
A laryngectomy is an extensive surgical procedure. The surgery typically involves removing the hyoid bone, epiglottis, and larynx, cutting through the cricopharynx, and finally removing tracheal rings 1, 2, and possibly 3. A round or oval shaped stoma, about the size of a 10-cent coin, is made at the base of the neck before the trachea is pulled up and sewn to the newly created stoma. This then forms a new and permanent airway. The airway is now only via the neck stoma, which connects directly to the trachea and lungs. There is no longer a connection to the mouth and the nose. After the airway is created, the remaining pharynx is resewn and remains connected to the esophagus. Sometimes a graft is taken from the arm, thigh, or chest, and this is used to ensure that the newly created pharynx, or neopharynx, is functional after surgery for eating, drinking, and voice restoration. A laryngectomy patient is different to a patient who wears a tracheostomy. A tracheostomy is a hollow plastic tube which is inserted into the trachea via the neck to ease breathing. It can bypass breathing through the upper airway only if a cuff is inflated. Patients who have a tracheostomy still have an anatomical connection to the upper airway.
As I can no longer have the benefits of a nose, I need to clean my stoma regularly and wear humidification so I don't experience avoidable breathing difficulty. At least 2 times a day, I need to look in the mirror to check the stoma that it's clean and there is nothing in the way that could block my airway. You could liken this to picking your nose with tweezers. When I am sick with a cold or have the flu, I need to do this more often as I cough and sneeze through the stoma. It generally takes an extra 10 minutes a day to do this. Usually I only clean my stoma twice a day, morning and night. But I remember when I was being a Larry, first up, I needed to do this a lot more due to the healing process. In summer and spring, especially the bushfire season, I might have to do this a few more times than twice a day. Most laryngectomy patients will wear a humidification device that attaches over the stoma to help keep the secretions loose, thin and clear. When wearing the device, it also helps keep on top of crusty phlegm from sticking around the edge of the stoma, which can be tricky to remove and sometimes causes the skin to bleed a little when peeled off. You can attach a few different ways to fit over the stoma, but most people attach it using a laryngectomy tube or an adhesive base plate. Generally though, I use a cloth cover with Velcro ties, and I find this works well for me. If I don't keep on top of my humidification needs, the secretions can become thick, build up, and cause me to have trouble breathing. Initially I used to have saline nebulizers over my stoma to help me humidify my airway. Now that I'm at home and well, having a steamy shower is enough humidification for me. And after surgery, my form of communication was writing everything down. And this was basically for about 8 months until the swelling actually subsided. And then I was able to actually use an electrolarynx. And this, when used, would vibrate at the base of the throat and move up into the mouth area, so I could actually voice and start communicating. After a certain period of time, I actually went back into hospital and had another surgery where the surgeons caused for a fistula or a secondary hole within the stoma, where they actually inserted a voice prosthesis. And that is the way I'm communicating at the moment. It's a more natural voicing method than using the electrolarynx. The way it works is I'm placing my thumb over my stoma and actually blocking it off. And what that does is that it moves air through the actual prosthesis up into the esophagus and up into the mouth, and your tongue and mouth actually do your voicing for you. So my food pipe is vibrating, whereas my larynx previously used to do that work. I can still eat and drink. My taste and smell is still strong, so I do enjoy a good coffee. Some Larrys lose their sense of taste and smell due to radiation fields destroying the smell and taste receptors. Like I mentioned before, when my voice prosthesis becomes old, it can leak, and that can make me cough and splutter with the drink going down the wrong way. But usually aspiration is not a problem, as the food pipe is surgically separated from the airway.
Approximately how often do you come into hospital each year?
Every 6 months I have my voice prosthesis changed, regardless whether it needs changing or not. And that's due to having 2 voice prostheses allocated to me through Enable, which is a government-run department. And the surgeons, I see them at the same time, and they do a scope down the nose and also down through the stoma to make sure that there's no recurrence of the cancer. But also, more importantly, they're looking for the correct placement of the voice prosthesis.
Have you been admitted to hospital since your operation?
After discharge, I actually had to go back into hospital about a week after the first operation, and that was due to my flap developing a fistula, and the fistula being a small hole just above the surgical scar here, and was nil by mouth after that. They had to provide me with a nasogastric tube for feeds and basically fluid intake, and that was there for 6 months.
When you come into hospital, do you identify yourself as a laryngectomy? And if so, how do you?
I don't identify myself as a laryngectomy first up. If I'm going in, I go up to reception, I start speaking, and people just think I've got a sore throat. So, but if I was actually going in for myself, yes, I would identify straight away as a laryngectomy. I would show them the stoma so that they're aware of it, and we go from there.
What is your biggest fear if you were to become unwell and rely on staff to look after your laryngectomy for you?
Biggest fear is not being conscious, and the emergency team not being astute enough to actually look for a stoma. An oxygen mask up here means nothing. It's just, that is one of my biggest fears. So as a take-home message, I'll be saying to all emergency staff, whenever a patient presents, just check the neck in case there might be a stoma there.